Hello, everyone. My name is Christy Amobi, and I work with C-RAD. Thank you so much for joining us today for our clinical education event. I'm delighted to introduce Dr. Nadeem Khan, a medical physicist and president of Advanced Radiotherapy Consulting and Synergistic Healthcare Solutions. Today, Dr. Khan will speak about the importance of SGRT for patient safety in radiation therapy. Throughout his career, Dr. Khan has been involved in multiple SGRT implementations with various providers and across various LINAC equipment manufacturers. Today, he will share his experience, he'll highlight cases, and he'll also briefly review SGRT reimbursement in the United States. With no further ado, I'll hand it over to Dr. Khan.
Thank you, Christy. That was great. Thank you so much for the introduction, and it's my pleasure and privilege to be here today with all of you. I want to thank C-RAD for giving me the opportunity for being here as well. This topic is kind of exciting and close to my heart because it touches two very important aspects of my medical physics career, which is quality and safety. And together we can combine that into patient treatment. So a little bit about myself, and Christy has done an amazing job just introducing me. I'm the president of the Advanced Radiotherapy Consulting and Synergistic Healthcare Solutions. The one part of my job that I really enjoy as well is teaching, and I'm a dean of faculty at John Patrick University, where I teach a lot of up and coming medical physicists and medical dosimetrists. I happen to be a fellow with the American College of Radiation Oncology and also a member of their physics committee. Formerly, I was a chief medical physicist at Oncology Hematology Cares, which is part of US Oncology, and I was also the vice chair of the Leadership Council as well. And many of our attendees today might have heard my podcasts. I do regular podcasts out of the gray, and last one was actually on efficiency of quality assurance. So I've had the good opportunity of going out in the clinics and talking to a lot of our colleagues on what's important to them. I've done about 120 plus audits and peer reviews when it comes to medical physics as well. And I know one thing we do as medical physicists is we fight for every millimeter, right? I mean, that PTV should be as tight as possible. So we're not treating any OARs. We are not treating any unwanted tissue. We're leaving healthy tissue as healthy tissue. That's why we do a lot of stuff on our imaging. We make sure the quality of the images are good. We do a lot of TPS QAs, monthlies and annuals, to ensure that the algorithms are doing what they're supposed to be doing. We work on fusion, whether you do a TPS fusion or a third-party fusion, to ensure that the contours are going to be as accurate as possible, reflecting what is there in the real world. We are doing a lot of end-to-end tests, right, from the CT unit all the way to taking our phantoms and irradiating them on the LINAC. We as physicists have done this forever, where we have fought for every millimeter on the laser alignment. I mean, we get calls first thing in the morning when lasers are off. We get calls halfway through the day when the lasers are off. And so we have to go back and look at that as well, right? Overall, the whole dosimetry, TG142, we are looking at millimeter after millimeter and after millimeter. And that has become the basis of what we are as individuals and how we work in our clinics as professionals as well. And that transcends across all the different entities and team members, whether there's radiation therapists, dosimetrists, physicians, and physicists in the clinic as well. So there are certain needs and wants, right? When I was working in the clinic with US Oncology, we had 4 sites across 4 LINACs. And the needs that we had, where we wanted tighter margins, we wanted to make sure that our certainty were a lot smaller than we were used to seeing, and we wanted higher accuracy as well. So those were needs, and I think these are the needs of majority of practices out there. What were our wants? Our wants were simple but real. We wanted a really good positioning system, a system that we could rely on, a system that we could extend beyond the SBRT use, beyond the DIBH. We wanted to have something that we could position all our patients with. I mean, looking at intra and inter-infraction management, that's what the essence of SBRT is. That is what the essence of DIBH is. The days of hold your breath across the intercom system are something we should be doing in the past. How do we move ahead with technology? I mean, what has become the standard of care? Well, respiratory gating has become the standard of care nowadays. We wanted to get a system that was well supported with literature and research. And we'll look at a few of those papers today that kind of enticed me towards going towards C-RAD. We want to have references. You want to have to visit reference sites to make sure that these systems are working in their practical use. You want to have a system that flows seamlessly into your integration of the workflow that you're following in your clinics. Do you really want extra equipment to be added to buy a system, or do you want it to fall in place with what you already have, regardless of what vendor you subscribe to? And most important thing is that getting a system is one thing, having support throughout the existence of that system, throughout its lifetime, and having training and education attached to that is very critical as well. These are certain things that I, as a chief physicist, was looking at when I went around looking for different vendors. Some of the factors to consider are the functionality of the system. I mean, technology is important. I mean, the world we live in today, technology today is irrelevant, obsolete tomorrow. So how do we strategize and look to the future? How do we see where our world is headed to in terms of our clinical and reimbursement arena here in the United States? How does a system integrate into what I already have? What else do I need to supplement and complement that system? It's things that I was looking at, or things we were looking at as a team when we went about looking for our respiratory gating system. How can we get best clinical value? And what is this thing going on with the reimbursement as well? Is something that we researched and looked further as well. So let's look at the functionality. I mean, gating systems, right? You can use it for SGRT, for partial breast irradiation, DIBH. That's a big one because, I mean, we are treating a lot of patients that we are asking them to hold their breath, for instance. So there's limited movement of tumors. Maybe you want the tumor away from a critical organ as well. So what we wanted is we didn't want to just focus on the site of the tumor or the isocenter. We wanted to see the entire body. We wanted to monitor the whole body because muscles move, muscles tense up. So if you're looking at the entire body, we have a better picture of what's happening to your tumor as well. We wanted to identify anatomical changes. Yes, we can locate them on cone beam CT, but what if we locate them while we're setting up the patient? And C-RAD does an amazing job with projecting the lights on patients so that you can actually identify depending on the different color of the lights. So it is something that we can use across all our patients when it comes to patient setup. So this became a true surface guided system for us, not just a respiratory gating system, but definitely a surface guided system. And the most important thing with this was that patient to control as opposed to technology taking control. So with the C-RAD system, in my opinion, the technology has actually moved to the patient. The patient can control their own breathing based on what's happening around them, the environment they're in. And that has truly accommodated the patient itself. We live in an age where we would like the patient to take control of their healthcare. We want them to be autonomous when it comes to their healthcare. And this is a great opportunity for them to do this. So they can actually control their own breathing and the colors of the room change accordingly on where if they are in the zone, out of the zone, or way above the zone, depending on the color of the light in the room. Or we can also coach them from the outside, which is great, right? Because you can have the best of both worlds, depending on the kind of patient you have and the comfort level that both sides of the LINAC have when it comes to treating this patient, both the patient themselves and the therapists that are outside the treatment vault. So it's a very patient-centric system. This system has brought patient into the center, and the entire technology has actually worked around those patients, whether it's being the panels themselves or the goggles that patients can wear to control their own breathing. So they can actually look at the zone and see if they're in the zone themselves or not. And positional checks, which is the setup of the patient for all treatment, doesn't have to be an SGRT. It doesn't have to be a DIBH. You can set up your extremities, for instance, on this and know if you are setting up the patient correctly. So it's a system that transcends all different modalities. A lot of our patients are treated through tattoos. They are set up by tattoos, but many of our patients nowadays are allergic to them. There are cultural reasons why people don't want to get tattoos. Some of these tattoos are permanent. So we're relying a lot on these lasers and these BBs. But with the C-RAD system, tattoos have become a little bit more obsolete. We are relying more on the surface guidance of the patients themselves. We have images that we take in the Sentinel system out in the in the CT, and those images are the ones that we track all the way through to the Catalyst HD Plus system on the LINAC. And those are the images that we are following and using to set up our patients. And then the shifts are made based on the contours that we're seeing on the patient, and it's verified with CBCT. So it's becoming a lot more laser independent. Goes back to what I initiated this conversation with. One of the things I said, that we are fighting for every millimeter when it comes to these lasers, and lasers are very finicky. We all know that. Temperature, pressure plays a big role with lasers from day to day, and having a different system to rely on the correct setup of the patient does put a lot of comfort to someone's mind, right? So this is one of the papers done by Dr. Stanley back in the University of Texas, and him and his team, they positioned over 6,000 fractions of patients over a 24-month period. Part of these patients were positions based on the 3-point tattoo alignment and shifted manually by the therapist. And part of these patients were done through C-RAD and surface guidance. And then KV-CBCT images were taken right afterwards. What it was found out that a lot of the patients who were done by the 3-point localization had less of a more appropriate movement to the current location, as opposed to a surface imaging that was done for C-RAD systems. So as you can see from this, the surface imaging got us a lot closer to where we needed to be than a 3-point localization with a tattoo. And this was across the board for a lot of different body sites: abdomen, pelvis, chest, and breast. As you can see from these graphs, being on the left-hand side with a lower magnitude of 3D shift vectors is a lot better than being on the right-hand side. And surface imaging was the one that got us a lot closer to where we needed to be when it came to the ISO center. Let's talk a little bit about technology after talking about the functionality. The two things that C-RAD is really top of the market and ahead of everybody else is when it comes to the end-to-end stuff and the reference markers. So let's talk about the end-to-end. I touched on this a little bit in a few slides back, where I talked about the Sentinel system that's in the CT room, where you actually get all the body images that are being transferred over. You're taking a surface guided image over there, and that is what follows through to the very end. That goes to your dosimetry, then gets transferred over to your linear accelerator. And there are other modalities, ancillary stuff that you can add to it, which includes your patient ID, patient positioning, biometrics, registration. All this is an additional to just the respiratory gating system as well, to make it a little more complete system. And in the treatment room, you will have with the Catalyst Plus HD 3 cameras, so it's more than the single camera that is actually visualizing and shining light on the patient as they're lying down. The other is the 2 reference markers, which is really neat, because we have patients who have different breathing cycles. We have patients who are deep breathers. So if one marker is not doing the job, we can actually monitor the patient movement through 2 different markers, depending on where we put them. So that actually brings a little bit more of a comfort level. I personally have used the 2 markers on several of our patients when one marker didn't do the job that it was supposed to do. C-RAD is a company that continuously works on upping their system, on working with different algorithms. Just recently, they've started doing a lot of work on non-rigid registration. I mean, this has always been part of C-RAD, and a lot more work on enhancing this feature is being done. I mean, when the templates are created off the reference, so there are reference images that are taken that have been taken off the CTs when the patient was lying on the CT on the Sentinel system. And these are transferred to the Catalyst system. Once the patient is there, templates are created of this reference, and they're fitted, they're warped around the live motion. And once that's done, then details are thrown on it. So the reason details are not thrown on the very first step is because that will just make this process a lot slower and a lot more cumbersome. So it's a step-by-step process as it completes itself, and this takes mere milliseconds to finish all of this stuff. So it happens really fast. The one thing that I was really interested in when we were going through this entire process of selecting which system I was going to go to, which system my team was going to go through, we wanted to look at papers. We wanted to compare on why I wanted to go with C-RAD. So this is another paper that has been done by Dr. Stanley and his group, and this incorporates active breathing coordinator, which is the ABC system. So about 60 minutes of both normal and DIBH breathing patterns were monitored, and a moderate deep inspiration breath hold was set at around 80% of maximum inspiration volume. So every time it was 80%. So there was no variation on that. And for each point in the baseline breast surface, a 3D vector system was calculated to the closest point. And then root mean square of the RMS was done for vector analysis. And then once that was done and they knew they were the right place, surface contours were sent over to figure out, okay, how far am I? And what was found that for every one of those breathing cycles, there was a slight disalignment when it came to this thing. There was changes in the lateral, longitudinal, and vertical, and it wasn't spot on. And subsequently, the evaluated images were about 7.4 millimeters off. So even when the breathing volume was accurate and the same within tolerance, the images were a little bit off. So which shows that, it wasn't a perfect match when it came to using ABC system for these patients. The next paper was something that I really, really enjoyed reading. This was by Dr. Simonova at the University of Heidelberg. And what happened over here is that they were a patient with 23 fractions. There were deformable registrations done for the non-small cell lung cancer off of the CBCT that was taken. That was the CBCT for every one of these fractions, which actually fused with a planning CT back in dosimetry. And then the treatment plan was thrown on this through the TPS to see, okay, how is my day-to-day CBCT comparing, and how much am I treating of the lung and the PTV for our patients? And the answers were pretty close. I mean, they were off about 2.4 millimeters for their PTVs, and there was hardly any difference in the lung volume that was being treated, which said that, surface guidance did bring more of a conformity to a lot of these treatments from day-to-day fractions. This one was by Dr. Annika Mannerberg. This was from University of London, Sweden. And what they did is they did about 21 patients and checked the setup accuracy. And this was done with setup accuracy for laser using the 3 tattoo system versus a surface guided. And their tolerance was 4 millimeters. What they found out that once again the number of patients that fell under the tattoo was a lot more than the ones that fell under the surface guidance when it comes to meeting the tolerances, and which once again gives us the comfort level that surface guidance is doing what it's supposed to be doing in terms of accuracy when it comes to setting up these patients. The last paper I'm going to discuss over here is something that expands beyond the horizon of just surface guidance and patient positioning. It's about the whole body monitoring. So this is a study that was done by Dr. Hansen out in Lund University in Sweden. And what they looked over here is that they had 4 patients encompassing about 52 treatments. And these were set up based on the correct planar KV imaging, and they did the KV imaging based on the thorax wall and the spine. The thorax region was actually scanned by C-RAD, by the surface guidance system, and images were taken. Now, the interfractional changes in the arms were observed by measuring the angle of the arm on the sagittal and the coronal plane. And what was found out that in the sagittal plane, the arm position was within plus minus 2 degrees from the median value 62% of the time, and plus minus 3 degrees in the 72%. Similar results when you looked in the coronal plane, it was about 81% plus minus 2 degrees and plus minus 3 degrees about 90%. So what this shows that, we could set up the patient correctly based on our KV images as we feel they're being correctly, but there is also difference in the position beyond that isocenter where we are not really zoning in. And if the surface guided system actually catches that, and I'll show that in a couple of clinical pictures I have following this. And we all know pectoral muscles, for instance, they tense up, they loosen up. That is going to change where your tumor is. And if we just keep zoning into the region of interest that we are in and not look at beyond what's going on there, then that might change the position of our tumor. Goes back to what I said in my second slide. We are all fighting for those millimeters. We as physicists work really, really hard on ensuring that our lasers are tight. We work very hard to make sure our output is within 1%. If not, we tweak it. We work very, very hard to make sure our imaging quality is the best. But then again, we are not looking at beyond our isocenter a lot of the times and seeing what's happening in the global aspect of things, right? So let's look at a couple of clinical cases here. The setup is very important. You want to make sure the patient is setting up correctly, and these images are prime examples of that. That we will know if the patient setup is good, if the patient is losing weight, if the patient is a little bit different than what they were a couple of days back by the reference images that we have already downloaded on these patients. It will not light up correctly. It will show that we are either too high towards these in terms of our SSDs towards the linac, or the patient might have lost weight, things like that. If the patient is wiggling their toes, and if they are a little bit off center, if they are not particularly set up correctly beyond the isocenter, we will notice that. We will see that their upper legs near the knees are not set up correctly. You might not notice that correctly on a KV image or a cone beam CT because we're not really looking in that area. But with the C-RAD system, it goes beyond that isocenter that you want to be looking at. Same thing over here. I mean, shoulders. Prime example, they can tense up, they can stretch out. We want to make sure that we look beyond that region and look at the entire body. And that's what C-RAD system does too. I mean, for example, with the KV image, with cone beam CT image, it's a snapshot in time. It's one time image that you take. However, with the C-RAD system, it's continuous, it's continual, it's an ongoing live image that you're seeing. If the patient decides to move a little bit during the course of the treatment, it's going to show. It's going to show because you're going to have different lights shining on the patient. And so it's a continual monitoring system. Integration is something that was very critical for us because we were being matched across all our sites. We wanted to make sure that we had the same kind of system that was installed. And we were very particular. I mean, we had the same kind of machines. We had the same kind of CT units. We were very, very standard across our 4 sites. So we wanted to make sure that this system kind of integrated well with our system. And C-RAD does that. C-RAD is vendor agnostic. It can be used with any of the vendors out there. They have a great positioning tool that we have talked about. They have a respiratory gating system that does an amazing job when it comes to tracking patients' respiratory motion. And all of this can be confirmed through cone beam CT later on as well, right? Because you should be using CBCT after you set up these patients and then treating them. So it's a system that falls very well into the whole scheme of things. In terms of what workflow changes do I need to make, very limited. The biggest adjustments was from the therapist side of things. There were absolutely no change when it came to the physician, physicist, and dosimetrist workflow. And I'll show you over here on what the therapist workflow changes like. Well, they want to make sure that the patient is positioned correctly on the couch, no different from what they would do for any other treatments. Assess motion management, and they can do that sitting outside on the treatment console by watching the breathing motion of the patient and making sure they're in the zone that has been created. Performing imaging, they do that with any other patient as well. Physician checks the CBCT and the portal. They will do that with any SGRT patient. The physicist verifies the shift. I make sure that I am seeing what I'm supposed to be seeing, and I'm going to read the parameters for the treatment to my therapist. And the therapist then monitor the C-RAD system. So in all essence, not a whole lot of changes when it comes to the SGRT workflow. If anything, it will make their process a lot more efficient because the setup is going to be a lot easier because it's going to be visual, optical lights that they'll be seeing to ensure that the patient is set up correctly. Now I've done both of these. I mean, I have implemented SGRT on a new linac that got installed, and we started from scratch installing a C-RAD system. I've also done installation on C-RAD system on pre-existing linacs, and the process is still the same. There's no different. is you're going to be accepting the C-RAD system, you're going to be commissioning the C-RAD system, and then that follows by training and education. So there's no good time or bad time to install this. It's whenever you're ready, and when you're ready to move forward into that world of respiratory gating or surface guided systems. So where is the future headed with our field? And I get a lot of opportunities to talk about this across the conferences I speak on. And we are headed towards an area where we want a lot more conformity, a lot more tighter margins, a lot more accurate treatments. And that's why we are upping our game when it comes to the technology. We are seeing a lot of our patients coming back for retreatments because of the higher quality of healthcare, because people are living longer. So we have to keep that in mind when we go into planning for our patients to make sure that our PTVs are going to be a lot tighter. We want to ensure that our patients understand the kind of technology we have. A lot of our patients that came to my clinics were asking for respiratory gating because they heard about this technology that was out there. And they want to use, we want to use our machine time judiciously, right? And having these C-RAD systems, having these surface guidance systems will make our life a lot easier, a lot more efficient, a lot more faster. And we will feel comfortable, a lot more comfortable in treating our patients to know that we are going after a tumor. We know where those tumors are, and understanding the fact that we are using a good system to treat our patients. Now, these are just value-added metrics that can help us enhance the quality of treatment and the safety and the accuracy of treatments that we're giving to our patients. And in all essence, it comes down to having those precise therapies. I mean, that's what I talk to my students all the time is how can we make our treatments a lot better? And I mean, going back 20 years when I first got into the field to where we are today, I mean, we have come a long way when it comes to the efficiency and accuracy, coming from four field boxes to IMRTs to SGRTs to SRSs. These are all precise and more accurate therapies and as well. SGRT reimbursement, I mean, I understand a thing or two about reimbursement. I actually have a fellowship on value-based care, and I have a fellowship with the American College of Medical Practice Executives. And so C-RAD has this partnership with Legion Healthcare that can actually assist you providing a customized pro forma. I mean, these numbers are just sample numbers over here. You might treat a lot more IMRT patients. I mean, the standard number across the board is about 60 to 70% that I see when I go to different clinics for their audits. And so that will change your numbers quite a bit. Also changes based on the area that you're in. The reimbursement model that you're following, the kind of payers that you have in your area. So at the end of the day, it is doable. There is reimbursement for this. It's just that you will have to have a more deeper dive when it comes to installing these in your areas. And obviously, for our listeners outside of the United States, that's not relevant, but it's more for our listeners in the U.S. Arena here. So I would strongly suggest reach out to C-RAD and talk to their Legion Healthcare before you even make a decision to see what kind of reimbursements will you be getting. And chances are that you'll be able to pay off the system in a short period of time. So those are all exciting times where we are sitting at right now, and it's exciting to see where we are headed. Just the concept of how the isocenter follows the surface is quite intriguing to see how the tetrahedrons and all the different technology that C-RAD has implemented to actually follow this isocenter in reference to the surface is pretty neat stuff. And it's an exciting technology. And I would strongly suggest all of you to take a deeper dive into this technology, understand how it's operational, and see if it's even feasible in your own clinics, because I'm sure that once you understand this process, you, like me, will like to listen and understand more on how this can be implemented in your own clinics and give more accurate and precise and safe treatments to your patients. I thank you again for listening to me, and I thank C-RAD and Christy for giving me this opportunity to spend some time with you this afternoon. Thank you very much. Christy, after you.
Thank you, Dr. Khan. That was really informative, and also thank you for highlighting a little bit about SGRT reimbursement in the United States. As a reminder, the Q&A is a moderated Q&A, so if you have any questions at all, you can go ahead and submit those using the questions tab in your GoToWebinar control panel. So you can just type those over to me. I did have a few questions coming in when I was, watching your presentation. So let me just get over those to those quickly. First question, what is the Q&A workflow for the various SGRT solutions?
The C-RAD system comes with its own standard QA, and you cannot use the system until the QA passes, which is kind of a fail-safe mechanism to ensure that the safety of the and integrity of the system is intact. So there is a phantom that comes with the system, both for the Sentinel and for the Catalyst, that you have to pass them in the morning. It looks like a rocket ship, to be honest, with like a spaceship, and you put it on the treatment couch and you laser it out, ensure that it's in the middle, and you run some tests with it. Same thing with the Catalyst system, similar concept. You're going to make sure that it's within certain tolerances. What we're trying to do over here as physicists to ensure that it is within a millimeter or so before we can actually start using the system, because it goes back to the same thing, Christy, that we talked about. We're fighting for every millimeter, so we want to ensure that the QA that it's going through is going to be pretty solid in terms of its implementation during the course of the day. And it probably only takes about a few minutes. I mean, I'm talking about not even 10 minutes for these things to be done with. In addition to that, the physicists will get involved with their TG142 protocols like we have here in the United States. We have both daily, monthly, and annual quality assurance that needs to be done on any of the systems. The only difference with the C-RAD system is that we don't have a surrogate over here. The body happens to be the surrogate. So a couple of those tests can be skipped out on or replaced for something else. So there's once again, not intensive tests, but pretty comprehensive tests when it comes to the quality assurance for all these products.
Okay, thank you. Next question, do you use C-RAD for non-coplanar SRS treatments?
You can use SRS. I mean, I know SCRAD has a lot of SRS folks out there that actually specialize in all of that stuff. I have mostly used CRAD for SGRT stuff. And they are doing a lot of work on stereotactic when it comes to the small field dosimetry and the small fields as well. Once again, the setup for an SRS field will be very much the same like you would do it for an SBRT, and it goes back to the same thing on using the system beyond just the modalities themselves. It's using the system for every patient that comes out, and you use it for all the patients that you want to treat when it comes to the patient setup and following any types of respiratory gating on these systems.
Okay, thank you. Next question is on the learning curve. You mentioned that you could implement an SGRT solution with, an existing LINAC or at the time of the purchase of a new LINAC. How is the learning curve for the therapists specifically, and then also if you could just comment on the other members of the team and learning curve?
Yeah, one of the talks I do during a course of a year, I pick different topics. One of the ones I've done so far is on change management. Change is never easy for anyone, and it needs to be thought through, and it should be implemented as a team. There should be a culture of change that's involved. And the learning curve can be as steep as you want it to be, or it can be as easy as one can take it, right? But the learning curve for C-RAD is not that difficult if you understand the theory and the physics behind it. What we did with our education team on site is we actually took a step-by-step process. We did not go through the whole process in one shot. We had stages where we went through different areas. We did some webinars before we even did an on-site training, so that we knew what we were getting into. Obviously, it was a lot easier after the first system was installed, because then the therapists from other sites can come on the primary site and see the system in its full functionality. But going back to that first site which we implemented, it was a step-by-step process. We did some webinars, we did some web access. C-RAD is really good with having trainers come on site multiple times and for different stages. Are you going to do a DIBH right now? Are you going to be setting up patients for SGRT? Are you going to do SRS? So all of that stuff goes in different stages, and they do a great job of compartmentalizing and rolling out these trainings at different intervals, and bringing out some subject matter experts on site as well to teach the ins and the outs and the tricks and the tips of C-RAD system.
Okay, thank you. Next question. Back to the Phantoms discussion. Is there a preferred Phantom to integrate with a WL test? Often square Phantoms struggle with SGRT systems.
Yeah, I mean, there's no, I know C-RAD system will, when I got it, they did not have a relationship with any vendors out there. Eventually they had, they have started having relationship with vendors. I just did an old school Phantom to get my QAs and quality assurance out of the way. I mean, I created my own tests. I had a comprehensive test about 15 different tests, 10 to 15 different tests that I created from scratch. And what I was looking for is more of the implementation of the amplitude, the frequency, and the duration of my sine waves, basically, as they come down to see. Duration of time was the same, and I did a lot of checks on my machine itself. And that is something we kind of shy away from because we think we're so concentrated on the system itself that we forget that we want to check certain things in our Linux. We want to make sure that our output is going to be the same with multiple interruptions. So we need to check that. We want to check that our profiles don't change. We want to check some QAs on our patients to make sure that interrupted beams will give me the same profile, dose profile. So all of that stuff combined together. I mean, I just had an in-house Phantom that would go up and down with different cycles to make sure that I was getting repetitive readings that was consistent across different times. But eventually we ended up buying a couple of different Phantoms because now that we had installed 4 different systems, we wanted to make sure that we could get something that was more consistent across the 4 systems to keep more of a consistency and accuracy across the board.
Okay, thank you. Next question. There's a number of comments thanking you for the presentation today. So thanks again for that. The next question is, if we treat breast with 3D, is SGRT beneficial as we treat with VMAT usually?
Absolutely. I mean, we look at SGRT as surface-guided radiation therapy, right? Why do we feel that the surface guidance radiation therapy only kicks in when we push the button to start the beam? It should start right from the very start. And that is something that I talked about maybe 3 or 4 times during the presentation. And it's something that I've taken to heart as well, is that we should have all our patients get set up by a surface guided system. That's what it's for, right? I mean, you should be setting up all the patients through once you're comfortable, obviously, and it's in your workflow, and you're because you don't want to slow down your workflow, yet you want to make it more efficient, more accurate, more precise, more safe. So using 3D patients, using VMAT patients, it should be irrelevant at the front end whether you set them up right. You should be setting them up through the SGRT phase and then take it on at some point. Maybe when we're really, really comfortable, and I'm not proposing that at all. There's a lot more work that needs to be done on that front. Is that do we start thinking once SGRT is a standard of care, is it's common it's common across the board, like electron cones are in our clinics, is as common as electron cones in our clinics. That do we consider, if we are comfortable with our system, to even cone beam CTR patients? I mean, that is a question that's out there. Do we move in that direction in the future, in the next 3 years, 5 years, 7 years, or something like that?
Okay, thank you. And the next question may require additional follow-up from the C-RAD technical team, but in your experience, what is the total uncertainty in millimeters of the C-RAD solution for SRS?
For SR, well within a millimeter. I mean, it will be well within like half a millimeter or less, because the system by itself is pretty precise. I mean, I'm sure whoever asked that question, C-RAD folks can send them a lot more literature, a lot more review on that. They can send them papers out there. But when it comes to the thing is that with any of these systems, we don't want them beyond the tolerance that we are actually used to. What we won't install a system. I, as a physicist, will not install a system in my clinic if it's beyond the tolerance that is allowable or I'm comfortable with. And C-RAD is well aware of that fact. And any system that they put out there will be well within a tolerance of SRSs and SBRTs. So, and I know, I mean, that having spoken with a lot of my colleagues that have used C-RAD and are on the other side of the fence when they work for C-RAD, is that a lot of work is being put into that SRS, since there is a lot of scope and a lot of research that's being done in that direction as well, including the concept where I talked about how the ISO center is kind of tracked based on the surface of the patient itself. And it's a really neat technology on how there are different tetrahedrons that are actually going to create this whole volumetric analysis when it comes to the movement of the isocenter based on the surface of the patient. It's really neat stuff, yes.
Okay, thank you. Next question, can the C-RAD system automatically turn off the treatment beam when the surface falls out of the set thresholds?
Yeah, it needs a response system. For example, I was part of the Electra group where we needed a response system, a response box, and it will talk to it. And once it comes out of the zone that has been created, it will automatically turn it on and off. Having said that, you still need two radiation therapists to be monitoring the system, because that's just safety. And you can't just walk away from it in terms of leaving one therapist by themselves, just because that's not the standard of care when it comes to all of this. But yes, the beam will turn off once it goes out of the zone. But then yes, that's a real possibility, and we have done that in our clinics. Yes.
Okay, next question. Are there any problems with using C-RAD for ring-based Linux like Halcyon?
That is a question that will probably be addressed by the C-RAD technical team as well, because I don't have experience with that. More of my experience lies with the Linux, so that is something that if we can just defer to the C-RAD technical team, they will probably be able to answer with the Halcyon question.
Okay, will do. And that's an important note. Also, I should have covered in the housekeeping, which is the C-RAD team can follow up here with any questions that need additional review and input. They're continuing to come in, so I'm just going to march through them with the few minutes we have left. Next question. Do you believe we could skip everyday imaging with a C-RAD only workflow?
Let's chat in about 3 years' time. That was my last slide over there, and I'm a visionary. I'm a medical physicist who likes to think beyond today, and that's where my business background comes into play. My doctorate in healthcare administration. We as physicists need to be very comfortable with what we have, right? Some of us are okay with the equipment we have, which we have been using for a long time. Others like to move in with technology and up their ante, right? So will we be where we are today 2 years from now? Absolutely not. You can take that to the bank. That's not going to happen. How do we make our process a lot more efficient is by looking beyond the box we're sitting in right now. And if you really trust your surface guided system, and you know what it's doing, and you've done all the testing possible, then why not? Why not? I mean, that is what these systems are made for, right? Redundancy is good, but too much redundancy slows down the process. At the end of the day, we want to make sure our process is of high quality. We want to make sure it's accurate. We want to make sure our patients are being treated. That's paramount. They're being treated safely and correctly and accurately. And if you can make sure that all of that is happening, and you as a team of professionals in your own practice feel that that's right, then start with the phantom and then move it on to see where you want to take it from there.
Okay. Next question. We have time for a couple more here. We're about out of our time. Were there any cases where you haven't seen value of SGRT? You sort of talk about it in terms of sort of using it for every type of case.
We have used it for pretty much every type of the case that you can think of. And if there wasn't value from what we have done, is because of we were unsure of how to use the technology. And that will happen. that will happen at the start of the time when you put in this process in place because it's still new. People are still learning that technology in your practice. So there'll be times when you shy away from using it when it could be of great value. But it's of value to every patient because you're going to be setting up every patient through this technology. So yes, I mean it transcends across body sites and modalities. But then again, you want to take a step-by-step process to get to that. So it is value added, as I said, to all of your patients if you use it correctly.
Okay, thank you. Next question, how do you balance between exposure time and the fluctuation stopping treatment beam with a 1 millimeter threshold?
Could you repeat that, please, Christy? I missed the first part.
Yeah, I think it's getting at how do you balance between the exposure time and the fluctuation that you might see between stopping the treatment beam with a 1 millimeter threshold?
Okay. I think I might understand that question correctly. It has to do more with the operation of your LINAC, and it has to do with making sure your LINAC is able to do that. And that is your MU linearity test to ensure that your MU is linear, whether you're delivering 5 MUs or 500 MUs. And that is a test that we normally do for our LINACs on an annual basis. And we do those linearities to ensure that our beam is going to, because we do a lot of SGRT treatments with multi-segments, and there are segments that are small which deliver only a few MUs, and there are segments that are large that are delivering hundreds of MUs at a given time. So we want to make sure that whether it's a small segmented MU or a large one, because of the end effects and things like that on a LINAC, that our LINAC is still going to deliver the same amount of dose. So that is a test that goes beyond just the system of C-RAD itself. It's an inherent property of your linear accelerator. And that is something that should be established as a baseline right from the very start before you even implement this system. So you don't have to have a C-RAD system or any surface guided system or respiratory gating system to actually do those testings on your LINACs.
Okay, thank you. Yeah, the attendee is just clarifying camera exposure time, so I'm not sure if that changes the answer at all in any way, but the difference between the camera exposure time and stopping the beam, the treatment beam.
Yeah, these are not ionizing radiations from the camera, so there's no dose coming from these cameras. So.
Okay, thank you. And final question, are there any problems you mentioned using SGRT for extremities? Have you seen any problems with treating lower extremities with C-RAD?
Haven't seen anything. I mean, treating lower extremities with C-RAD. What we're doing right now is going beyond the isocenter, which is a central point. We're going beyond and looking at the whole body. So, I mean, if your muscle is twitching or something like that, that's going to throw the tumor volume off a touch. It might throw it off by a few millimeters, but then again, we as physicists and physicians are going after every millimeter possible because patients are coming back for retreatments. We don't want to be treating anything more than we are treating. And should be treating. So what we're watching is the body contour where it's supposed to be during the course of the treatment. And yeah, so there's no harm, no foul by using C-RAD for extremities either. So.
Okay, thank you. Is there anything else that you'd like to add this afternoon?
No, I just want to thank our listeners. I mean, some amazing questions there, Christy, which makes me hope and believe that we are looking beyond where we are today and we're looking to the future. And respiratory gating happens to be the future of our field as well. And some of the great questions were like, well, do you see getting rid of cone beam CT and imaging? I mean, eventually sometime in the future it might happen, but we need to be very, very careful and confident where we are today in our own systems. And doing that makes us as physicists the visionaries and the strategists that we should be implementing these technologies in our clinics. So no, thank you very much to C-RAD. Thank you for moderating and thank you to all the listeners. This was great. Thank you so much. Really appreciate it.
Thank you. On behalf of C-RAD, thank you so much for providing this clinical education activity for us today. With that, I will close today's session. Thank you so much for your attention. And on behalf of C-RAD, I hope that everybody has a wonderful rest of your day. Thank you so much.